Hello everybody, my name is Klaus Bachet. I'm originally a German otolaryngologist who specialized then in upper airway disease, worked in Ghent, and currently I work in Münster and Guangzhou, China. Depending on the region where you live, you might use different criteria for type 2, or in other words, the likelihood of describing a type 2 inflammation is different according to where you live. In Europe and the US, for example, asthma comorbidity in patients with chronic rhinosinusitis with nasal polyps would be a strong marker of type 2 immunity. If the patient is not asthmatic, you could look at the blood eosinophils, and an increase of blood eosinophils above 150, even more above 300, would also indicate strongly that there is a type 2 inflammation in the sinuses. Well, first of all, we don't like to use systemic corticosteroids in these patients. And I think as a diagnostic indicator, it's also not valid, because different kinds of inflammation would be suppressed by corticosteroids, which have a very broad action. So it's not helping. Of course, in the past, these patients may have used corticosteroids, and you can make an estimation of how much of this inflammation could possibly be reduced by an adequate treatment, but not by the corticosteroids, such as biologics. When we talk about surgery in patients with nasal polyp disease, I would not call it radical. I would rather call it a complete surgery, which means that you remove the mucosa of the sinuses or within the sinuses as complete as possible. If that is difficult or the patient is not the right patient for surgery, then of course you have to try other possible pathways. And certainly nowadays, with the advent of biologics, we have the possibility of treating the patients with a biologic drug first, see what the result is, and then decide whether we actually need surgery and how we should modify this surgery versus surgery at a, let's say, untreated condition. Nowadays, we have quite good signs, clinical signs of such a treatment. Very frequent, for example, with dupilumab treatment, the patient would consider that there is smell again. They have smell and taste back. And that can happen within the first 4 weeks and is a very strong sign of a response. It takes longer to actually shrink the polyps. That can be 3 months, 6 months, with a clear shrinkage. But until the polyps might disappear, it might take a year of treatment. So we have to understand that there are different responses to your question at different time points in the treatment. And perfect situation is that you have within the first 4 weeks an answer to this question by, for example, the smell coming back or the nose getting better possibility to breathe. And until you actually get finally the result that you want, and that is a control of the disease so that the patient is nearly or is symptom-free. That question I would first ask, what was the biologic? There is a sort of an increase in effectiveness in reducing nasal polyp size from mepolizumab to omalizumab and to dupilumab. In that case, where there is a dupilumab treatment, we expect 85% of the patients to respond with at least a -1 nasal polyp score. What would I do with the other 15%? I would here combine that treatment with surgery. And the question really is, how long would you do the biologics? To make this decision, I think 3 to 6 months longest are a good measure. you would then interfere surgically. And then the question is, how do you prevent that patients get polyps again? And that might be, again, a biologic, unless there is really no response to that biologic treatment, but that's by far the minority. Maybe some single patients where you really do not have a response to a dupilumab, for example. For me, the aim of the biologics is actually to reduce the number of surgeries or even to make them unnecessary. So clearly, I would first work with a biologic, then see whether I need a surgery. And so it is biologic first, pre-surgery or pre-planned surgery, then the analysis of whether there is a surgery needed. And these analyses always have to be happening together with the patient. The patient's opinion, the patient's symptoms and aims have to be taken into that calculation. What I think is very important, that you continue the post-operative treatment long enough. And that is something where we still have to learn in the future. In some patients, you may be able to stop after some years, see whether that condition, that status of near no polyps can be maintained. And then you can come again with a treatment, and only in a few patients you might use a continuous treatment to keep them controlled. It is very decisive that we select patients carefully as type 2 chronic rhinosinusitis with nasal polyp patients, because otherwise our treatment approach has no target within the disease of the patient. So it is really, it's not too difficult, but it's really necessary to show that there is a type 2 immune disease. Otherwise, I would not even start a treatment with a biologic that is directed to type 2 inflammatory reactions. So, in other words, if you are not sure that this is a type 2 immune reaction, you should try from the biopsy, from the blood examination, from former biopsies, you should try to figure out, is that really type 2? 85% of the patients in our country, in Europe, would have a type 2 immune reaction. In other countries or continents, this might be only 50%. So it's very important to define that before you start a biologic treatment. This is, of course, an often asked question where we do not have a lot of experience yet, as we are just starting using biologics in nasal polyp patients in, meanwhile, several thousand patients in Europe. We have to learn here. We do expect that, and we know from the trials so far, that once the patient responded to the treatment, that these patients also stay sensitive to the biologic. In that way, I would say, well, as long as you give the biologic, the polyps will be shrinked, disappear, and will not bother the patient anymore. I do not think that there is a time point yet where you can stop with the biologic and then expect that this stays lifelong in a non-polyp condition. So most probably you have to think about long-term treatment in these patients. Although you can, of course, play with the intervals maybe, but this is something we really have to learn more about in the future. First, I would say that more and more patients and doctors will discover biologics, and they are deciding on a biologic first before surgery and then on the need of a surgery. And I guess that biologics will be more and more used in the future. To my knowledge, there is no long-term perspective that would sort of make the treatment with these biologics either inefficient or complicated. So I think the perspective in the future on the future landscape of treating polyps with biologics is extremely positive. We might have other biologics in the future, but each of these drugs has to show that there is efficacy and adverse events freeness, I would say, or very low likelihood of adverse events. And then we will see whether the effectiveness of a specific drug is better than another drug. And that is, of course, what will change our treatments with the number of biologics that are available. Well, I think first we have to very clearly define surgery for nasal polyp disease or chronic rhinosinusitis with nasal polyps. I think there will still be surgery. First of all, because maybe biologics are not everywhere available or accessible. Second, we see in the discussion with the patient that patients sometimes clearly go for surgery in the idea that they want to have it solved fast and hope that this then stays. They might choose to have a surgery, and I always try to convince them that they start with a biologic, because even if I think the surgery can do sort of a good job here in this patient, it might be necessary to have other treatments on top of this surgery. And it is better to understand whether the biologic and which biologic works in the beginning, because then you have, to our knowledge, a tool for the future of this patient you can always use to treat this polyp disease. I wish you really great times with this new experience. I'm sure you will do the best for your patients. And whenever you have a question, just ask it. I'm always there for you to answer questions. And I will see you again in the near future and hope to hear a lot of success stories. Goodbye.